My name is Dr. Damien Gatinel. I work in France in the Rothschild Foundation. I'm the head of the Anterior segment and Refractive surgery department there. So I use several premium cataract technologies. On the diagnostic side, I use several bunch of instruments aimed at precising the exact visual impairment of the patient's eye prior to the surgery, and at the surgery time we have access to various advanced surgical technologies, including femto laser cataract surgery. The first diagnostic tool I would use is just a simple interview. I would first really try to appreciate how the cataract is impairing the patient's vision, because I think it's important, especially if you consider multifocal IOL implantation. So I would try to really quantify and qualify the exact visual symptoms, such as glare, maybe backlight issues, which are sometimes causing not a loss in visual acuity, but some significant visual disturbances. And then I would try to correlate these symptoms to objective metrics, which can be derived from various examinations. So, for example, I systematically perform a HD analyzer, OCAS measurement. This measurement provides me with the OSI metric, optical scatter index metric. So it's a very nice way to quantify the level of light scatter which is caused by the cataract. And it really guides you and helps to appreciate really the intensity of the cataract. The second thing that I systematically perform is a topographic and aberrometric combined examination. I use the OPD scan 3, and this provides me with elements related to the cornea, toricity for astigmatism and toric IOL implantation, and also corneal regularity, which must be preserved if you think of implanting a multifocal IOL. I can also have access to some internal aberration component, and again appreciate the effect of the cataract, which is sometimes, for example, a myopic shift, etc. And finally, we have developed in the Rothschild Foundation a metric which is based on the image provided by the Zeiss IOL Master 700. It's a swept source OCT acquisition. It's just a cross-sectional section of the crystalline lens. But if you analyze it in terms of gray level on the image, actually you can define some threshold which again are really well correlated with the presence of visually significant cataract. So that's the things I use before the surgery. When it comes to the selection of the treatment options, I believe that the surgeon should try to be as comprehensive as can be, but it's always a case-by-case selection. It may be still good to explain to a patient why you won't use a premium IOL in his case or her case, because if you don't do and if you don't allude to this possibility, the patient may feel afterward, when he's aware of that you didn't want or didn't know about such technology. So, and in other situations, some patients do not really spontaneously express the need of spectacular independence. And I think it's your task to expose those new possibilities, because some patients are not aware of it. I would say though that because of the increase in information over the internet, I have patients now coming for cataract surgery who first express the need of spectacular independence before visual improvement. And this is really the refractive dimension of the cataract surgery today. So once you have this in mind, and if your patient's flow is similar to mine, I think you really need to be as comprehensive as can be to avoid post-operative deceptions and disillusions, I think.